helps my job. So if you see a literature review of what we have on osteotomies around the knee, for a total knee, these are procedures which are done and required for very specific situations in our total knee arthroplasty armamentarium. And what is very significant on reviewing the literature is that there is a deficit of level 1 evidence or randomized controlled trials on who needs an osteotomy and where it exactly is needed. Also, there is a lack of evidence to say which are the patients who will need osteotomies and what are the actual results on medium-term and long-term follow-up. So osteotomies in around total knees are required in stiff knees for surgical exposures. They are used for soft tissue balancing for the rigid varus knees. They are required for soft tissue balancing for the lateral side on the rigid valguses, and they are needed for extra-articular deformity corrections. So if you actually see what kind of osteotomies are required, a stiff knee will require something like a distal augmentation, which is a tibial tubercle osteotomy. The soft tissue balancing for the medial side of rigid varices need the reduction osteotomies and the sliding medial condylar osteotomies. The soft tissue balancing for the rigid valguses need a sliding lateral condylar osteotomy, and the extra-articular deformities require osteotomies, whether it is for distant deformities in the femur or the tibia for an extra-articular correction, or doing a primary intra-articular correction for deformities closer to the joint. So the tibial tubercle osteotomy, a lot has already been explained by Raj, makes my job easier. So the basic thing is to understand what is stiff. So less than 50 degrees range of motion is stiff, less than 30 degrees is ankylosed. India has a lot of very, very good peer-reviewed literature, and Mrinal has actually given a classification of stiff and ankylosed knees and basically defined whether the stiffness is in flexion, whether it is in extension, and what happens when the knee has very limited range of motion of less than 30 degrees. So the solutions are either a proximal release in the form of a quadriceps snip, or a proximal release in the form of a VY-plasty, or a distal release in the form of a tibial tubercle osteotomy. Now, where and how you do this is basically a statement of what is the pathology in a given situation, and especially in knees which are stiff in extension and knees which are ankylosed and have less than 30 degrees range of motion. So that's a 55-year-old, had a stiff knee, underwent a tibial tubercle osteotomy. The basic principle is you do a 7 to 10 centimeter longitudinal osteotomy, which is about 1 centimeter wide. It allows us very good exposure distally. Once we have done our job, the osteotomy can be actually you take a suture through the native bone, through the medial sleeve, through the osteotomized segment, and you put it back using a 5-0 ethibond. Sometimes encerclage, could use screws as well for augmentation, and these knees actually do fairly well. The medial reduction osteotomy and the sliding medial condylar osteotomies. So very often we realize that the rigid ones, the very rigid varices, actually at the end of our releases will still have a lateral opening and a medial tightness, which might need release of the superficial medial collateral ligament in the pes. The risk and the danger of doing that procedure is that if we are not very careful and if we overdo that procedure, we will have a flexion space which is much more than the extension space, and then we start walking into the realm of a more building in more constraint into those knees. On the other hand, if we leave behind that residual medial tightness, then we have a potential for an increased varus thrust, an increased wear, and an increased possibility of early loosening in these knees. So basically the standard protocol of reliefs of the deep MCL, the posteromedial capsular release, the semimembranosus release, taking off the osteophytes from the proximal medial tibia and the tenting osteophyte from the proximal medial distal femur, basically runs into a problem when there is a mismatch of or a medial lateral imbalance and that is where your reduction osteotomies come into place. So after careful tibial cuts, you assess what is the size of the bone defect, and a reduction osteotomy helps us to correct the tightness in extension. Sometimes the defects can be very severe, and then you have to go to the base of the defect, and in those situations you will need to undersize or downsize the tibial component, which will actually cause us to cause cause increased reduction osteotomies on the medial and posteromedial side, thereby giving an increased medial release. So these phenomenon will sometimes still leave behind a medial lateral gap mismatch, and if the medial lateral gap mismatch is more than 2 millimeters in full extension, that is where we need to think about a sliding medial condylar osteotomy. The osteotomy is done about 5 millimeters lateral to the most medial part. The osteotomy goes obliquely and proximally, but distal to the adductor tubercle. Once we have done the osteotomy, we take tag sutures onto the osteotomized fragment, fix our implants, and then once the implant is fixed, titrate the flexion, the medial lateral gap or the medial lateral space, and fix those screws with wires and convert them with cancellous screws. So the sliding medial condylar osteotomy is required for rigid varices which do not correct with despite the releases and the reduction osteotomies, who have extra-articular deformities which will leave behind a residual medial-lateral space imbalance, and these are performed after the cementation of the implant in 45 degrees flexion of the knee, and you need to be careful with how you handle these patients in the post-operative phase. Sliding lateral condylar osteotomies, essentially this is a patient, 51 years old, did not walk for 22 years. We did a bilateral hip, came with a flexion valgus, very rigid deformity, and most of the valguses will correct with your standard releases and your osteophyte removal, your standard posterolateral corner IT band release, not having to do anything with the popliteus. But sometimes the rigid valguses will need a release of the LCL and the popliteus, which predispose to medial lateral laxity, and that is where you need to do your lateral sliding femoral osteotomy, which will restore the balance, which will restore your mechanical axis. And the last in this group of patients is the extra-articular deformities. Mrinal has already touched about them. So the basic two crux of these deformity corrections is whether the deformity is close to the joint, which tends to affect the imbalance much more, or whether it is distal to the joint. So distal to the joint needs a separate extra-articular correction. Closer to the joint and the severity of deformity, Wang has this fantastic rule which says that less than 20 degrees of femur and less than 30 degrees of femur, the deformity can be corrected with an intra-articular correction, and the cut of the distal fragment of the tibia should not violate the collaterals or should not go beyond the tibial condyles. So those are patients who are very amenable to this single stage correction of deformity, and they will do extremely well in the longer term. So to take home, the osteotomies around total knee replacements are usually required in stiff knees for surgical exposures. They are required for soft tissue balancing in the form of reduction osteotomies and sliding medial condylar osteotomies in very specific situations in very rigid varices. Similarly, in very specific situations in rigid valguses and for extra-articular deformity corrections. And the deformities and the osteotomies are the TTOs, the SLCOs, SMCOs, reduction osteotomies, and the intra-articular and extra-articular corrections. Thank you for your time.